Next, it's my pleasure to introduce Dr. Haitham Khogeer. Dr. Haitham, he did a training and postdoctoral fellowship in hematopathology and leukemia, lymphoma, and molecular genetics at MD Anderson Cancer Center. He is a consultant hematopathologist at King Faisal Specialist Hospital and the former hematopathology training director. Dr. Haitham is going to present a topic titled with molecular pathological finding in neoplastic hematology. Welcome, Dr. Haitham. Mic is yours.
Assalamu alaikum. Thank you for this invite. Thank you for this invitation. So this is my disclosure. So what I thought I would do today is starting broad and then get into some specific vignettes using disease that I think a lot about in my daily practice, and also to continue what Dr. Mansour he started with, which is acute myeloid leukemia, as a specific example of some of the things that we have learned in the past few years, and which was the first step for discovering a target therapy. So we'll start with the classification, genomic landscape, what are the age difference in mutational landscape, mutation evolution, clonal hematopoiesis of indeterminate potential, which is very important topic. And at the end, I will end my talk with some take-home messages for my colleague and fellow and resident. So in line with the new era of medicine and medical technologies, all of us believe on the precision medicine as an ideal clinical practice, where we really need to match a patient with the specific therapies based on specific alteration in their health and disease status. I think we reach to this belief because of the significant advances that have been achieved on the pathophysiological and genetic knowledge of numerous diseases because of the innovative genomic applications. So this figure summarizes the timeline of various milestones in the evolution of the genomic classification of AML. As you know, AML was classified initially by FAB in 1976 based on the cell lineage of the leukemic cells and their differentiation status derived from the cell morphology as well as cytochemical staining of the bone marrow cells. Then the discovery of the recurrent cytogenetic abnormality led to a novel classification system by the WHO at 2001. 2008 classification reflects the significance of new molecular insight that have become available since 2001 and opened the door to include genetic abnormality as a criteria for classification at that time and also in the future. So the current classification 2016 acknowledged that the genetic abnormalities can be used as an objective criteria for defining of some entities and as a target for some approved chemotherapy. So this is AML based on the classification based on WHO 2016, but I want to mention the diagnostic karyotype remain the most powerful prognostic indicator in AML and form the basis of the current diagnosis and prognostic score. To give an example quickly of the key rules of cytogenetic that play important role in the diagnosis of AML, so the WHO classification has established that patient with the translocation 821 in version 16, 1616, and translocation 1517 should be considered to have AML regardless of the blast percentage. Moreover, by dividing patient into 3 risk group, favorable, intermediate, and adverse, cytogenetic has been widely adopted to provide the framework for the risk-adopted treatment approaches. In certain situations, also cytogenetic allow for prediction of effective therapy, such as patients with BMR-RARA who can have a benefit from the ATRA. This is one of the famous picture in the genomic landscape of AML. The data shown on this slide from German Austrian AML study group. It includes data from over 1,500 patients between the ages of 18 and 84, treated with the 3 different clinical trials with intensive chemotherapy. 111 different genes were sequenced, and among these genes, 5,234 mutations were identified among 76 genes. 96% had at least one driver mutation, and 86% had more than 2 or had 2 or more than 2 driver mutation. So the molecular analysis demonstrated that there were several mutations that were either prognostic or predicted, and they are also targetable. For example, FLT3 abnormality occurred in 1/3 of the patient, and these we can target it with the FLT3 inhibitors. NPM1 mutation occur in 30% of the patient with diploid karyotype, and these patients have very favorable prognosis with intensive chemotherapy, provided that the mutation is not associated with the other adverse mutation. We also know that about 20% of patients have either IDH1, IDH2 mutation, and we can target them with the enasidenib or ivosidenib. But what does this all mean for the classification? Briefly, with the ability to sequence the gene involved in the leukemia genesis in multiple patient samples using advanced genomic techniques, we were able to refine the risk stratification and even the classification of the AML. So the author pointed out that nearly half of the patients in this cohort would not fall under the WHO molecular classification criteria, despite having disease driver mutation. So beyond the existing WHO subgroup, the author suggested an alternative classification method based on specific statistical analysis for their own result, and they proposed a 5 new molecular subgroup in addition to the recurrent cytogenetic abnormalities. So there is a distinction between system for classifying patients with the AML for diagnostic purposes and a system for predicting the outcome of the AML. So for prognostic purposes, the system should be stable and durable based on the fixed biologic properties of the disease. So the focus will be on the causative driver mutation. For prognosis purposes, the system should be flexible and adaptable, evolving to reflect the advances in the treatment and often being influenced by changes in the disease severity. Let's take an example. Although the WHO lists FLT3 ITD as a molecular genetic alteration significantly affecting the clinical outcome in patients with the AML in a specific cytogenetic subgroup, it doesn't group FLT3 mutation into a single category because it occurs across multiple AML subtypes. Therefore, they rather divided them into many risk groups. So this slide summarizes the new ELAINE classification, and this already adopted in the 2017, and it might evolve in the future with some recent discovery. So what you see among favorable profiles, some mutation that consider favorable beside the core binding factor leukemia and ABL, for example, patient with the NPM1 without FLT3 abnormality or with low allelic burden of FLT3 abnormality less than 0.5%, are considered favorable. Also CEPA biallelic, even though it is uncommon, is also considered quite favorable. But when you see at the adverse group, patient with the FLT3 ITD and with the high allelic frequency, more than 0.5%, are considered adverse, but this is before the introduction of the FLT3 inhibitor. The prognosis of these patients is changing very quickly. At the bottom, you see TP53, which probably consider worst of the worst mutation, And now there are some ongoing effort by different scientist group to have target therapy such as ABR246 and CD47 antibody for such mutation or for its critical pathway. These data show interesting findings regarding the age-related differences in the mutational and structural alterations in the AML. So in the top, childhood AML, like adult AML, both has a low somatic mutation burden, less than 1 somatic changes in the protein coding region. In the bottom, childhood AML is more frequently impacted by common cytogenetic alteration than adult AML. However, the landscape of somatic variant in pediatric AML was markedly different from that reported in the adults. Alteration in the RAS genes, KIT and FLT3 were more common in the children. For genes such as CPL, GATA2, Wilms tumor make both the frequency and the site of the mutation often differed between the children or different between the children and the adults. Another striking difference between adult and the pediatric AML involved a high frequency of mutation in the DNA methylation related gene are more common in the adult AML compared to the pediatric, like DMT3A, IDH1, IDH2, and TET2. Mutational complexity of the AML. So this circus plot depicts the relative frequency and pairwise co-occurrence of the common molecular mutation in the AML. So basically, it connects the notion that if you have one abnormality, you are going to have a large proportion of the another abnormality. So let's take an example. So patient with the NPM1 very frequently have a FLT3 abnormality and DMT3A as well. And also FLT3, patient with the FLT3 ITD are common to have an NPM1 also. So all these can be mixed up together. One common feature of neoplastic progression is clonal expansion or evolution with a genetic or epigenetic alteration. In the other word, there is a clonal architecture of AML, and this can differ at the diagnosis and at the relapse time, where in this slide shown here, each color represents a different genetic profile or different clone. So when the patient are treated and then relapse, they can relapse with the different clone, major or minor or treatment related. For example, this example, no change with in the relapse clone. It's similar as a diagnosis. Here there is differential clone expansion. In this example, we see gain of novel subclone, here complex clone. And now I'm going to talk a little bit about clonal hematopoiesis and how it translates into difficulties for us in interpreting the result, especially measurable residual disease following the therapy. So the definition of the CHIP is basically the presence of the clonal mutation in hematopoietic stem cells and progenitor cells in the absence of hematological disease. In other words, the presence of clonal blood cells population associated with the leukemia driver mutation at a variant allelic frequency of 2% or greater, but in the absence of cytopenia or the WHO-defined disorder. So we know very well that the incidence increase with the age, and most commonly one or few mutation in the gene recognized as early event in the myeloid neoplasm include epigenetic modifier like DMT3A, TET2, splicing factor such as SF3B1, SRSF2, and also TB53 and JAK2 These consider the recurrent mutation in the clonal hematopoiesis of indeterminate potential. Its incidence increased in patients with the solid tumor, which also be as a result of its association with increasing age, and it does have also potential association with the higher exposure to oncologic therapy or chemotherapy. This paper was published in the 2014 and demonstrate that mutation that discovered by West whole exome sequencing were very rare in the person younger than 40 years of age, but rose up in frequency with each decade of life thereafter. Then the author searched for mutation in genes implicated in hematological malignancy, and the most commonly genes or the mutated genes were DMT3A, TIT2, SXL1, TB53, JAK2, as most of the paper they mentioned. Another important observation was about 693 of the 746 persons with detectable mutation had only one mutation in the set of the gene that were examined. These findings consistent with the hypothesis that these persons had clones harboring only in the initiating lesions. Okay, so we know that clonal hematopoiesis can precede AML development. But what happens after you treat a patient with the AML? And what is the fate of the clonal hematopoiesis? And what happens to the clonal size? And what are the long-term effects of the patient who had a residual clonal hematopoiesis following induction therapy? So in this study, the author looked at the series of the patient with the AML who achieved complete remission. And then they analyzed the dynamic of persistent clonal hematopoiesis and investigated its clinical implication after they sequenced them by using targeted panel of 295 genes by NGS. So variant with the greater than 2.5% allelic frequency at complete remission were defined post CRCH, post complete remission clonal hematopoiesis. Two subtypes were defined: persistent CH, the variant were detected in the original AML sample and persisted after complete remission. And emerging CH, the variant, were not detected in the original AML sample, but emerged after attaining CR. So following induction chemotherapy, 48% had a post-CRCH, among which 40% had persistent pre-leukemic CH alone, and 1% has emerging CH alone, and around 7% have had both. So let's look at an example to explain more. So this is one patient that was treated with the chemotherapy. As you can see, that at the diagnosis, these variant allelic frequency of the various mutation, and on the other side, on the right side of this graph, you have the blast count. So when they treat a patient, the blast count goes down. Also, the mutation of NPM1 and NRAS goes down. But you can see DMT3 and TET2 actually persist. However,
3 minutes, Dr. Haitham.
Okay. However, they also found that allostem cell transplant, as we'd expect, is able to eradicate the mutation right. So here the patient has a DMT3 that persisting, but once they are transplanted, the DMT3 disappear. So in summary, post-treatment clonal hematopoiesis may be associated with phenotypic abnormality, but it's not necessarily residual AML. Consolidation and maintenance therapy have minimal effect on the post-remission clonal hematopoiesis, but allogenic stem cell transplant may be curative. The take-home messages for my colleague and fellow and the resident regarding the testing, the utility of the genetic testing depends on who are you testing. It really depends on what is your test probability and how you will interpret the result of that test. And think about what you are testing, single gene or multiple gene, whole gene or hotspot. Also think about the test sensitivity. So there are some diseases where small clone matter particularly if you are thinking about prognosis. So if you find a small clone of adverse mutation, that might be something to know, that might be something that really changed the outcome for this individual one. And if you are doing less sensitive testing, so you might not identify this. Finally, think about when you are testing and why. So there are certain stages during the disease, of course, that can be amenable to genetic testing, where you can learn different things. Are you doing this at the diagnosis? Are you doing this at the doing it primarily for prognosis or at relapse? So this may determine what kind of panel you are interested in looking at, and again, how you interpret those genetic mutations. So in order to prevent poor utilization of the molecular testing, both either over or underutilization that may lead to increased cost associating with unnecessarily molecular tests, and also to prevent misinterpretation or misapplication of the molecular result, and also in order to provide or to give the best clinical integrated report to clinician in order to provide the optimum treatment management plan, I think this can be done by applying a special approach that we can call it diagnostic management approach, which mainly driven by hematopathologists with the collaboration with the clinician and the scientists or laboratorians. So the goal of hematopathologists is to create guidelines and algorithm to ensure that molecular tests or the other ancillary tests are ordered on the right sample at the right time for the right patient to meet the clinical need of each patient, and create integrated narrative report that really is the result interpretation for the clinician. And again, of course, we have to not forget the other collaboration team, clinician and scientists and laboratorians, where they have great input either in the result interpretation, in the technical management, test validation, test development, and also in the management, treatment, or result interpretation. And I think this is my last slide. Allahumma anfa'ni bima 'allamtani wa 'allimni ma yanfa'ni wa zidni 'ilma. Thank you very much.
Thank you very much, Dr. Haitham, for this excellent comprehensive presentation. We have two questions here. First question, do you have any classification of AML based on protein and metabolites profiling? Because the fact that not all gene translated to protein or molecular function.
Actually, till now, the new or adopted molecular classification that adopted before, the one that I showed you, the recent, but maybe in the future, maybe we'll have this classification. True.
Okay. Another question, do you think, is this the time that we have to screen for CHIP in a specific medical condition?
See, CHIP, as I told you, the molecular test should be requested at the right time. For example, if you have a patient who's not suffering from anything, no cytopenia, everything, so why we should screen this particular patient? But if the patient has, and as I told you, CHIP can be common with the other solid tumor, and he will involve in the, for example, he will be a donor for his son or for his daughter, or and I think at this time maybe it's a good idea to screen them. But the important thing, how you're going to interpret this mutation, because the clonal hematopoiesis, it doesn't mean the patient has a cancer, but it can be the first signal in the future for this patient to may transform or develop AML in the future, not at that time.
Okay. I cannot see any more question. Thank you again, Dr. Haitham. And I will handle the mics now to my colleague, Dr. Ayman. Thank you very much.